Pearls.
I like pearls.
Okay, and you're gonna bring up my case, right?
Usually
Okay,
like
thanks
to
you
do that.
guys, as always, for being available for me. Let me see if I can change my screen a little bit so I can see this better. Hold on. Okay, it's getting better. There we go. Okay. So this was a very recent encounter. It was the 10th. Not quite 2 weeks ago. And this was a 17-year-old female who's mixed race. She has Medicaid insurance, and she was new to our program. Let's see, scroll down. I think there should be like more of a history before my questions. So so we'll go up to the top back in a minute. So she has been using heroin on and off for a couple of years, smoking. She had started using weed prior to that. She has a 9-month-old and came into the program because of her involvement in CPS. She's retained custody of the infant, but they're involved. She is living with her boyfriend's father and stepmother. Her boyfriend is in treatment in an inpatient program, I think someplace, I can't remember where. And she is starting back into high school and was referred to us to get treatment. She most recently had been using 2 stamps of heroin a day. She had used Suboxone that she bought on the street for a month and did well on it, but then did relapse after about a month. And when she doesn't have any history of overdose. When she came to see me, she had used heroin 2 days prior, but had gotten Suboxone since then. So she had been taking the Suboxone. At first, when I saw her age, I thought it was going to induce her on site. We usually allow people to start their medication at home, but she had been on the Suboxone for a couple of days and had 6 milligrams the night before. She did not use heroin when she was pregnant. And it was interesting because at one point in the visit, her mom came in to the visit, and her mom said, she doesn't live with her mom, but her mom's involved, and said that she was really worried about her daughter and really wanted her to get treatment. And this young woman had told me that she had been using heroin for a year. And then when the mom came in, the mom said she's been using for 2 years. And the patient said, well, no. And the mom said, well, you started 2 years ago. You just didn't use when you were pregnant. So that, I just think that's interesting. Her either her perception or her communication about her use to me. She had dropped out of high school for a year, but they had she said the high school had encouraged her to come back and said they would work with her. And I think that was kind of related to the baby, not related to the substance use disorder. I'm not sure that they know about that. And she has used meth on occasion. It is not her drug of choice. She had most recently used 3 weeks ago. She had a past history of cocaine and alcohol use, but said she had not used either of those in over a year. Her screen showed bupe only. And let's see. So is that the end of my history, Elizabeth?
Hey Jen, this is a
hang on one second. I'll be back in 1 minute.
No worries, I can scroll up a little bit too.
Sorry about that. That was an emergency UPS pickup of a medical device. So anyway, okay. And if you can go back down to the bottom, I'm sorry.
Oh, no, you're fine.
Let's see. Yes. So she said she thinks she might have depression. I don't think I did a PHQ-9 that day. Her COW score that day was 5. And she was a very pleasant person, very attentive and interactive and alert. Let's see, is there anything else below that? Elizabeth, can you scroll down?
I can go back up.
That might be the bottom of the case. Okay. So yes, we can go back up to the questions. So this was the youngest person that we have had referred to our program. We had permission from her biological mother and her and also the people that she's living with, the adults that she's living with, to treat. And we had the patient's permission. She's 17-year-old with a kid. She, as I mentioned, has been using Suboxone that she's been buying on the street. And so my questions and the team's questions, we decided to proceed with treatment because it seemed really important. And I checked on dosing. I looked up dosing and just sort of figured she had felt that sometimes she needed 6, sometimes she needed 12. So I gave her 8. And thought I would see, how that held her. But it was an interesting case for us because of her age and the both the clinical ramifications and the legal ramifications. I will also say that since then, already in 10 days, she has struggled to stay with the program. So she missed her follow-up medical meeting last week. We called her. She said it was because she was in school. So we're trying to think about, maybe we need to accommodate her at a time that's not in group if she can't get away from school. She also did not attend any NA meetings. And I was a little bit interested about the NA requirement for a 17-year-old. Now we have a lot of meetings that we can offer her that are closed meetings with our peer support person. And I thought that might be a little more comfortable for her. She would be familiar with those people, but they're also, a lot of them are at the noon hour. We have a couple in the evening. So anyway, there seem to be some interesting implications because of her age, about her care. And already we're seeing that in the first couple of weeks because of school. So I'm curious your thoughts. That's the story. And of course, I would take any questions.
Excellent. Thank you so much again, Jen, as always. Does anybody have any questions before we go into, the comments?
This is Diane. I had a question about her being 17 going to the NA meetings. Would that be an issue because she's a minor or?
Yeah, I mean, that I guess was my question because of her age. I mean, I'm sure that I assume that it's allowed. I don't know. It just seems a little different because she's young.
Sure.
It is allowed. They don't have an age requirement, so she would be welcome there. But as far as like safety, I could see that being a concern. But I mean,
and what I advised her was to try it, and if she felt uncomfortable, to let us know. But now this week, what she has said, my understanding of what she said that I heard just now from one of my partners, or two of my partners on the call, is that she just school interfered with her going. But she's got.
One thought, if she has access to the internet, we do have a lot of online meetings now. A lot of our patients do with schedule conflicts, and they're putting it 24/7. So if she's available, she can do an online meeting for any time, to be honest, if you have that information.
Yeah, we're allowing people to do one online meeting and requiring 3 in person. And so I guess the question for us would we change that for some reason because of her age or because of school? But right now we're giving her the same requirements as everyone else in the program. Dr. Heasted, I see you unmuted.
I heard it twice.
Well, me too.
Is it? I don't know the answer to this. Are there any HIPAA entanglements with having a teenager along with a bunch of adults in a group? because their records are even more so sealed typically. I'm not sure about that because I don't think we've ever had any underage people in COAT that I'm aware of. So I don't know if there might be an issue with that. So, Katie.
Yeah, that's a great question you ask. I feel like we've had a rare exception of a 17-year-old in code and maybe a rare occasion of a 17-year-old in IOP. But you ask a great question. I don't know if we at the time paid attention to, what are if there's any legal, I don't think there would be any difference. I mean, kids can be in groups together and be sharing confidential information in those groups, and sort of same thing with the adults that are in a group and, kind of willingly sharing their confidential information in a group. So I don't think that there is a difference there, other than just making sure there's really a good informed consent with that patient of, who she'll be in group with and what are the benefits and the potential risks of that, since we can't guarantee, we can do as much as we try to guarantee confidentiality, but can't.
Yeah.
Great question.
Is she like new 17 or old 17 too?
She's
Like,
17 and a half.
okay.
She'll, I forget when her birthday is, but she's right at the halfway point. So she's midway between 17 and 18. And you can just see that my partner, Angela Barker, just chatted, and Andy saw her today to prescribe, today to prescribe for her, and spoke to her about having her school be her meeting. So that's, that it looks like we're going to possibly be flexible on the meeting requirements. The HIPAA I had not thought about particularly. I mean, I thought about her being in a group with adults, but I hadn't thought about the HIPAA aspect of it.
The other issue you have is if she's not emancipated, which can be at 16, until she's 18, you still may need parental consent unless there's some exception that's been granted.
We have parental consent. Yeah, we made sure of that.
I don't know the answer about HIPAA. I think that's really intriguing question from a state law perspective for OB-MAT, specifically in the regulations. It says you can treat anybody 16 and older in OB-MAT clinics. And if, just what you were talking about, unless, if they're emancipated, you don't need any special consent. If they're unemancipated, then you need parental or guardian consent, but you've already got that. So from a state law perspective, you're all good. I don't, but there's federal laws and the privacy laws. It's a really good question.
And let's say that it were an issue, then I'm assuming that we would have the option to treat her individually and prescribe, and then just have her do individual counseling, not group counseling. And do you all think that clinically that would be better?
I think it would depend on how well she does in a group setting. If she would tend to benefit more from, peers, then maybe it'd be good to keep her there. But if she can get the same benefits from doing individual counseling, it might be fine.
And I think another thing to consider is it depends on how interactive she is with her child's life, because not only is she going to school, but she is a new mom. And so that's a lot of work too, doing both of those things. And then on top of it, attending NA meetings, and attending individual therapy and group therapy, all these things stack up. So that might be another consideration you might want to take into account.
Yeah, that's a good point.
Have you encouraged the family to do Nar-Anon or anything, or Al-Anon?
I did not. It was the first time I had met the mom, and I did not talk to her about that. But I certainly could, and that's a good idea.
Just with a grain of salt in case there's any MAT bashing or anything, which typically, I don't know, it can be, it's more of an NA thing, so.
Thank you so much for everyone's great questions and input. Jen, did you have any other questions?
No, I do not. And I want to make sure that my two colleagues are on here, Amy and Angie, if they have any questions, in case they can unmute. Thanks, you guys.
Of course, yeah, please chat those in and or we can go back to it at the end of the didactic if they have any other questions. It's not a problem at all. All right. Mark, are you ready for your didactic portion?
Yep. And I've already
Perfect.
been kicked off Zoom once today, so
Oh, no.
disclaimer.
I'll take over. I'll do
I've
fine.
been having
I'll
a
know, I'll
month.
know
You can
exactly all the
handle it.
words.
It's urine. You got this.
Totally.
So disclaimer in the meantime, while I'm getting to the share screen thing, disclaimer, I'm having a Monday, folks. But others have much worse Mondays, of course. So I went to teach this morning and I was having a very interactive class that was going to be a huge discussion based off of videos and for 2 hours and the audio wouldn't work. So go figure. Went back to
Oh,
the
that
office
sucks.
and WVU kicked me off of email. So at that point, I'm like, am I still getting a paycheck? Turns out I am. Then I had to go to the restroom and there was a line and I'm like, you know what? I'm out of here. So this is just not working out today. I'm going to go do echo. But at no point does one get peed off, right? And I'm trying to tie it in here. I'm trying. It's Monday. All right. So we're going to go over urine drug monitoring. Feel free to throw some chats in here or there or whatever. I am by far, I don't know who's actually an expert when it comes to urine. I mean, seriously, except those that work obviously in toxicology and for the companies. So when folks have questions, more often than not all the time, it's really about going to the company that they use, because turns out everybody's paying for the help along the way. So that's a big thought, but we want to be able to, entertain the conversations along the way with those folks. So we'll go over a couple nuances here or there. Hey, that's working. Learning objectives. We're going to go over urine drug monitoring overall. Let your eyes really quickly read the rest. I've used this before with Echo, so at least 60% of you have seen this. Whether you remember it or not is a whole nother ball game. But I'm a big baseball fan. Entire family is. And I actually used to be an umpire in the Baltimore, Maryland area. Could have done some other things in that ruckus of a neighborhood, but ended up JV and varsity umpiring. And you got to really love the game to do that thing, because here's a picture of like the Cubs who took like a century, if there's any Cubs fans out there, to end up winning a World Series or really even getting to the playoffs. And they're all happy. Fans are all happy. And, there's my mouse. Check out this dude right here. He is trust but verify. He's not checking out anything over here. He's looking down here, folks. All right. He's looking down to make sure that the runner batter, I believe it's this guy's leg right here. So that guy, that his leg touches that plate. Because even though he hit the ball over the fence, if he does not touch each of the bases before he lands in the dugout, he can then be called out. So the boring job of this guy is to trust but verify, which is pretty much what we do when it comes to various risk mitigation strategies overall. So from baseball back to urine. First thing is terminology. Boy, it's a big thing when you're talking about things like cannabis or marijuana and all that great stuff, but it means a lot when you're talking about this stuff too. More often than not, things are spoken technically incorrectly, but we could all get off that pendulum too, I guess. But urine drug monitoring is a way to go over both testing and screening, which are significantly different. But no matter what the heck you're doing, we do have to remember that we're not just looking for the illustrious diversion, misuse, all the negative stuff. We're also looking for what I would call conversationally tough guy syndrome or tough gal syndrome. Say somebody ends up in a painful situation and is given one possible answer to that being pain medicine, and then they don't take it. You can catch that within utilization of urine drug monitoring as well, because that could prevent centralized pain down the road and all of those things as well too. All right, so just keep that in mind too. It's not always the negative, although our minds go there, of course. So what's some differences here? Here's more of the structured version of looking at things. So urine drug screening, it's the immunoassays, quite popular over the last 2 or 3 years or so. I'll touch on that in a hot second here, but compared to the testing, which is $30,000, $40,000, $50,000 machines that are remarkable, they are definitive. That's pretty much the biggest difference, of course. That and the bottom line here of the dollar signs just going relative. Of course, if something is definitive, it's going to cost more. And that's not easy to incorporate into practice. A lot of the things I'll briefly discuss here are really highlighting it's kind of like I'm a drug rep or a urine rep for tests compared to screenings because of all the nuances, but there's a reality of the cost as well too. So we'll touch on some of these along the way here too. But as far as the cups, the immunoassays, it's one fancy cup or really simple stuff, of course. The liquid is added, it travels its way on up the immunoassay, and it's the control is later. So that tells you that the liquid actually made its way through, and then whatever you're testing for is along the way there as well. It's similar, or it's literally the same thing as pregnancy tests. As I usually say, if you're expecting the world out of the cup, you're undoubtedly going to be disappointed because that would be the same thing as expecting the little stick to tell you if it's a boy or a girl. That's just preposterous. It's not an expectation of the screening or often labeled testing. It's just not a thing. I don't know how to go about this without provoking any polarity in folks, but if Marco here took care of the world the last 3 years, I would have started from day one to say we need to distinguish immunoassays as screenings and definitive tests, maybe PCRs, as tests. There is a significant difference, and probably in about 2 or 3 years, we'll learn a couple things about all the rapid antigen COVID tests that are out there. But it brings it home a little bit of what we actually expect out of these things that are commonly conversationally called tests when they don't really stack up for that. So my apologies. That cough is something that requires Augmentin, not Paxlovid. Got checked out yesterday. All right. So urine drug screenings. So we're back to the cups. There's many different cups at this party. For employment, there are the various screenings that are utilized all across the country are usually the 5-panel, maybe 7-panel if you get fancy, but never really beyond that in most cases. However, the rest are available. The larger the number, the more things that are within that screening that are reasonably being looked for. Not perfectly, but looked for. But you always keep those core 5 or core 7 along the way. So hopefully this chart kind of portrays that there. This is actually an important one. This could be discussed for any type of immunoassay. Is this thing labels tests or screening? But the false positive or false negative propensity. What all this is basically saying is if you average out these numbers, you got about a 1 in 3 chance of having a false positive or a 1 in 3 chance of a false negative. I am no statistician. I am a pharmacist, but I know that you can't just add them together and say 2 out of 3 times it's going to be wrong. That's incorrect. I also don't know what the exact number would be when you're combining those, but maybe somebody else does. But at the very least, it's 1 in 3. And some of the stuff we'll talk about here is really talking about false positives because that gets cooler conversations. But there's always also that thing very important for clinical practice of if it's a false negative, meaning that the patient is utilizing substance XYZ, but it's not showing that in the screening. That's concerning along the way too, but doesn't come with many of the cool stories. So that's just a reference for that for you. This one I've shared before. Sometimes I add things, sometimes I subtract them. But what this is all basically saying is that if somebody is utilizing one of the right column here, one of these cross reactants, they may produce a positive, albeit false positive, urine drug screening for whatever substance is being screened for on the left. So if somebody will go from the top here is on an over-the-counter NSAID like ibuprofen, there is a chance that they could have a false positive THC, even though this is labeled cannabinoids, screening. It just comes down to the structures. I'll visualize that for you here in a moment. But that goes for the same all the way down this list here. And that's something that whenever, there's certain situations that demand, less finances being involved. So if a screening has to be utilized, we need to remember these things along the way is the bottom line, of course. So you see in the chat here. Okay, just people's names. So this is my rendition of saying, I don't know, I got to pull opioids in somehow, right? So here's the structural classes of opioids. as per yours truly. I do have, it's adapted from something from Dr. Volkow, apparently, bottom left there from NIDA. She's amazing. I got to chit chat with her at RX Summit a couple months ago. But anyways, the bottom line here is that not all opioids prescription opioids, especially, are of the same structural class. This is where MedChem gets fun somehow. Not again, but originally. Whereas the phenanthrines are the main ones. As you can see towards the left, it's the vast majority of them. But for somebody to think that you're going to do a urine drug screening for any opioid and someone's utilizing fentanyl and it's going to show up in that screening, I mean, you might as well go bang your head off the wall, right? It's just not going to happen because it's a different structural class. Those little antibodies in the immunoassay are looking for similar structure. That's it. So you got to be towards the left here to stand a chance. There's also, of course, all the workarounds for various urine drug screenings. Some would say that could possibly work for urine drug testing as well. That might be a little bit of a stretch, but you know, it's an amazing world out there. There's various home remedies. You can find information on them online all the time, whether people are utilizing bleach or vinegar, you know, the extremes of pH, basically. Cranberry juice, you know, not only for UTIs, but for UDS, right? There's synthetic urine. You could either make it. There's the recipes for you. Have fun. Or you could purchase it. There's various things available towards the bottom of this slide. Some myths include just dilute it. I mean, the percentage of whatever substance it is will go down, and that, you know, is perceived to have effects on the ultimate outcomes. Or there's what we would call substitution, just using someone else's urine. So the reason of sharing these, of course, is just realizing what information is out there conversationally, online blogs, word on the street, whatever it is. These are the majority of things. But when talking about these, either the cup or the fancy $50,000 machines, the bottom line is that the screening is a conversation starter. You can't rely completely on it, as most, if not everybody, knows, of course. Whereas a urine drug test it holds up. Clinic and court, it holds up. Bottom line. I would point out, though, that as you can see here, yeah, I do have the thing. This is not a test. Even the thing is labeled as a test, and it's not a test. For our School of Pharmacy, even within our Health Sciences Center, this was something in my other role as in charge of basically our clinical rotations. Healthcare students beyond student pharmacists, but everybody always has site requirements, things you do before you go to the site. One thing that we had everybody doing, like everybody else, was urine drug screenings. And I'm like, what's the point? So we worked with a local clinic to get the pricing to be equal for screenings and tests. You go figure, my gosh, talk about the ultimate negotiation. But that way it was reasonable for our students, and now they do testing. They're the only ones that I know of for whatever reason, because yours truly knows enough to watch on these things too. So, all right, question that came in here. Jennifer Boyd's asking, so if someone has a very high pH, does it raise suspicion they are trying to manipulate their screen? I'll say, for example, a pH of 9.1. Oh, you said, for example, at the end. And I know you had that question kind of earlier too, Jennifer. Hopefully they shared the ideas there. So going in this presentation one, I can't go back, that's fine. But on those possible myths or workaround things like 2 slides ago, all of those things are attempting to fool usually a screening. The tricky part with that is that there's certain things set up in the background that are just, you know, stereotypical normalities that are always going to be there. Things like pH. All those things are usually screened or tested in the background to make sure that there wasn't an attempt at manipulation of the substance, the sample, I should say. pH is one of those. So 9.1 will be up there. I believe it's easily outside of the general range. I can't think of the range right now, but it's reasonable. 9's not in it there. So things to keep in mind. That would be, but it's tricky. How we go about those conversations dictated from anything with the screening or whatever, it is not easy. I know, or anyone can say, oh, this is exactly how you go about that, and it works every time. Because you know, it is the pharmacist, but it's the practice of medicine or whatever profession we got going on. We're always learning too. So it's, you know, proceeding with that emotional intelligence, and also confidence along the way too, especially if you have the testing done. So, all right, so patient cases. I tried to add a few in here. Where's my little, there we go. We got another one there too. If you're looking for jokes, just go to this fishy guy here too. So couple, I think we just have a handful of cases, and we're actually, yeah, we're really good on time today. So you got a patient, like to keep it simple. The current medication list of this patient is taking lisinopril, because doesn't everybody, for blood pressure. Also using diphenhydramine, because never talked to a pharmacist about the second generation antihistamines for his seasonal allergies, and also a multivitamin, because I mean, why not, right? That being said, that's it. And the patient has a urine drug screening, and it is screened positive for opiates, even though it should say opioids. So what do we do? I'll take the liberty of saying what everybody would answer. Of course, have a confirmatory test. And when doing that confirmatory test, all is well. Because the test is showing no concerns there, no levels with morphine or even the one of the rapid metabolites of heroin, or some of the oxy neighbors there as well too. But diphenhydramine was there. That's all well and good. You could have gotten that from that list, that chart I had earlier, but you probably want more. I know I would, and I do. So structurally speaking, how anyone can go about this is, it's like the one time in history that either Dr. Google or Wiki can actually help you out. It's all about the structures. So if you're wondering if something could produce a false positive for a urine drug screening, emphasis on screening, before the confirmation testing, then you need usually to not look further than the structure, but that is not perfect. I'll have another case to show you that or two. But here, for those that enjoy red, I've taken the liberty to highlight the structural similarities on a very basic level, like what a freshman in college would look at. Not us, looking at every detail. But you can see, okay, 2 rings and that oxygen with like 2 arms on it there. Huh, interesting. Well, that's exactly what the antibodies in the immunoassay say. Oh, looks like a duck, talks like a duck, must be morphine, right? So that's the generality of what we're looking for, just structural similarities. More to come on that. All right, so another patient case. This patient's telling us they don't utilize any medications, like if that happens ever, but they are attempting to stop tobacco smoking. So important thing there. That's great, but now you've got a urine drug screening that says positive for amphetamines. What, anybody want to? The handout I don't think was sent up. But anybody want to venture to say what could be going on here? All right, the nays have it. So you do urine drug testing, because that's naturally, if the screening's not working out or there's questions, you confirm. You're still up a boat, right? Because now you've got, okay, well, there's nothing, but not really. All is clear for the patient, because now you don't have concerns of amphetamine, but at the back of your mind, you're still wondering what was going on with that screening, or was it just one out of 3, false positives, I guess. What could possibly cause that? Well, what else is going on? Well, bupropion, Zyban, Wellbutrin, in this case was dispensed by a pharmacist for smoking cessation, because some states actually allow us pharmacists to prescribe, dispense under collaborative agreements. And then, if people don't communicate all along the way, would have no idea and it wouldn't be in the medication list. So perhaps that's what happened in this case along the way. But the bupropion would have that similarity along the way. Might as well show it to you here. So the similarity, this one gets a little bit trickier. All right, I got my red marker out again here, and okay, there's a ring, and then there's that amine group, the nitrogen, but it's not exact. I mean, if you look at it, it's, the nitrogen 2 arms and an H, nitrogen 2 arms and a methyl. It's a little bit different. So could you even count that? Well, the nitrogen's there. Where it gets tricky is what you can't see when you utilize Dr. Wikigoodle or whoever, is the 3D structure. And it's really hard to describe that, because I physically can't show it to you unless I got a really fancy machine, and I don't. I couldn't even log into my email today. But when you look at this in the 2D, maybe, but in the 3D, then all of a sudden it starts looking similar. So the reason I show this is that I wouldn't want to come across like, oh, you could just look at this and ands are done, we're good to go. It is or is not similar. There's also the 3D structure going on as well too there. So, oh, I just looked in the chat and looks like Sarah, you got it right. Wellbutrin. I thought I didn't see that there, but someone did get it correct on that last case. All right, so next up here. Sorry. So again, a new patient that states, yep, still not using any medications, and urine drug screening says positive for THC. What the deuce, right? You do a urine drug test and no worries. Interesting. At this very point, there's multiple reasons that could be forming here for this. One of them would be beyond what's going on. In this case, well, the patient was doing some gardening, went down to the dollar store and bought some ibuprofen, like I mentioned earlier. It's on that list of false positives as possibly producing. So, and saying it the second time here earlier and with the case, just to really drive that home of we got to watch how we go about things with the urine drug screenings, especially, but really monitoring overall as well too. Because when we think we have all the information, we of course might not. We all have instances like that, but it's not always deceit. I mean, the guy might have just forgot. He bought it at the dollar store. You don't associate that with, healthcare usually, although it's either dollar store or Dollar General did appoint a chief health officer or something like that. I don't really know what they're doing with that, but if anybody knows, feel free to let us know. But anyways, it could be easily forgotten when you think about it. So it's important to have those conversations, not to the perhaps to the like, I need to know everything in your body, but have you taken anything from anywhere? You might not have purchased it at a pharmacy or a clinic or wherever, but anything anywhere. So ways to help with that. As far as the ibuprofen, it's kind of similar to that last thing where we can show some 2D similarities, but there's like a gazillion other things with a ring and an OH. So it's really comes down to the 3D structure. So yes, we can look into the structures online, but it's not perfect. And 2/3 of the cases here are trying to show that too. So it's not always an art along the way. All right, one or two more here, I think. Patient case. So you got somebody where they have a lower than expected pill count. One of their prescriptions being oxycodone. Pill counts down, radar's going up. So you do the urine drug screening and still positive for oxycodone, but your radar is still up. You're like, hey, the other pills, where are they at? So of course, going to do a confirmatory, and of course you get the same results. Urine drug test says oxycodone. Patient's like, told you so, doc. But anybody want to venture to say what's off here? Well, I have some of the answers already on here, but not specific to the test. What you certainly want to be seeing in this regard is the metabolites. This is an art, not a specific flow chart, but the metabolites are not present in this urine drug testing confirmation of the sample. So what could be happening is, did somebody divert the rest of them, sell them, share them, whatever we want to use for words? And how'd they get around that? Well, did they take a pill a couple hours right before the appointment? It's not really random if it's tied to an appointment. So you just pop a pill a little bit before and then the oxycodone's in there, but the body may not have had time to metabolize it. So the metabolites won't be there. And then in that particular case, this would be a busted. But we really have to have those conversations, what all these things lead to. Again, like that slide with the conversation starters and conversation leaders. So all that being said, that's all well and done, but then what? Like, where do we even go? And it's typically not a clinician that's the expert at that point. It's usually the folks that talk about motivational interviewing, perhaps that emotional intelligence thing of, Doug's got the car and then what? And he's actually here today. I totally stole that concept from you, Tom. The other one of at least the other pharmacists on this call. I don't even remember when, but years ago, there was a conversation with APHA, our umbrella professional organization. And he was like, yeah, it's kind of like a dog catches a car, then what? And I'm like, exactly. So I tend to use that picture a lot. It's like the only one I could find. But how do we go about it? So if you have confirmed drug seeking and diversion, Hopefully in the background, there's also that patient provider agreement or contract. And hopefully in that agreement contract, it says what to do. It says if things, if it, hits the fan, like one of those cartoons showed, this is what we're going to do. And that's nice and easy then, because that's what you're going to do. If it wasn't included in your agreement or contract, the homework here today is to go back and check your contracts and make sure you could add it in there, right? But if it wasn't, then you proceed onward. Keeping things in mind, treatment can continue, say it's even pain management, it's whatever else going on with non-controlled substance therapies. A little bit dicier in the MAT world, obviously. But in the back in the pain realm here, I guess we'd say, referring to people. If anyone's safety is a concern, that's when law enforcement comes into play. As a pharmacist, I could say I have been in those situations where things get a little bit dicey and you need to be able to leave the building alive and safe. And it's when those things become a concern, that's when law enforcement get involved. Point being, it doesn't necessarily need to be automatic, depending on the scenario. But no matter what, just keeping up the respect for everybody, proceeding with the, hey, you never know if you're wrong, depending on the situation, all that kind of stuff. But no matter what, you got to uphold the law too. So you be all nicey and all that stuff, but you got to uphold the law too. So a big thing is avoiding patient abandonment. So no matter what, documenting everything thoroughly, usually not a problem when scenarios like this pop up. As far as specifics, there could be a termination letter, patient signs it with a witness, or you could do that in the mail, certified mail with a receipt. 30-day notice in the letter, offering to transfer records wherever else, referring someone to perhaps hopefully multiple professionals who may accept the patient care, and keeping all that stuff in mind there. One note though, when it comes to the patient abandonment, this seems to come up a good deal. If somebody has a urine drug test with results there, or even multiple thereof, and the test says that the patient has not been utilizing the medication, it's not generally presumed to be patient abandonment to no longer provide the medication, because their test would show that they have not been using it anyway. That can get tricky, but keep that in mind along the way too, because we all need that confidence and compassion along the way too. I use our pain clinic as one of the examples when talking about one of many examples when talking about urine drug monitoring. But in that clinic, again, it's a pain clinic. It's not MAT, although there is MAT efforts going on. All patients have urine drug testing. I should have added a period there. Period. It's just how it is. Side note, by the way, when I travel around doing talks and all that, I always say I work in Utopia. They do. Results are available within 24 hours. You as the clinician don't need to go and get those results. You can have things set up. I'm sure many of you actually do. You have it set up where the company, the software notifies you if something's awry. So you can proceed with I don't need to necessarily check. It'll tell me if something's a little bit off. And that's phenomenal because we're all, only given 20 hours a day, 24, something like that. I know some presume 82, but whatever. There's certified letters, there's conversations. But there's no deviations is probably one of the bigger things. What I would leave everybody with beyond discussion is, boy, what will the future hold? Will the people with the smartwatches please stand up? We're on Zoom. You don't need to. What are these things going to do in the relatively near future? They can already assess, your heart rate. Their pulse ox, I think, is one of the things. They're working on blood pressure. Who knows if things will pump or whatever. But the point being, they're already able to look for chemicals or substances. So, I mean, is it really that far off to being able to say, hey, one of these things probably charge you more? Would be able to tell you your morphine in there or your whatever, your metabolites. It's not preposterous in 2022 to think that it's within a decade. I don't know the year or whatever. But food for thought there. And how in the world we'd go about that is beyond me. I mean, do you get to watch at the office or do you wear it all the time? That being said, there's toilets available for thousands of dollars all across the planet that do all this stuff in the comfort of someone's home. They'll tell you all kinds of stuff. I don't have one, so I don't know a ton about them, but I know they exist. Typically in Asia, they utilize them more, or at least they sell them more, so I presume they utilize them more. The thing I'll leave you with, it's not in the handout when you get that tonight or tomorrow. This is the kiddo. We keep him offline, so I threw some shades on him there, so that way technically his face isn't on there. Of note that on the left there, that's a balcony at North Myrtle Beach, and in that picture, I believe he's about 3 or 4 years old. We'll go with 3 years old. And your minds are thinking like, oh my gosh, did you really let him? It looks like you're a couple levels up. Did you really let him pee off there? No. That is actually a bottle of water that he's holding. And he had a blast just squeezing it off of the balcony. What you're looking at is my point of view, which I immediately took a picture and said, I will show that to everybody so that we eliminate all judgment when it comes to urine drug monitoring. We got to remember that we don't always have the full picture. It might just be a kid with a bottle. He's not actually peeing on someone down at the pool. Because then later in that trip, he found that in a store that said no peeing off the porch. And I, had to put 2 and 2 together there. So that's little Luke helping us out here today. He also posted on LinkedIn yesterday, and man, that kid's an internet sensation. I got like 7,000 hits on that thing already. Talking about how yesterday was Fentanyl Awareness Day. In case anybody didn't know. So the whole 1 pill can kill idea. I gave you the answer to the online question that I posed out there. So I believe that's that. I'll stop the old screen share so we can see our faces again.
Awesome.
Thoughts,
Thank you
questions?
so much, Mark. Your presentation is always fun, entertaining, and gives us a lot of knowledge too and learning. So really appreciate that and love the adorable peeing off the balcony picture.
Luke made his Echo debut. I apologize. I once again did not do the Buffalo Plaid nor Hawaiian, which I actually have a couple. We went there earlier this year. It's been a rough day.
Yes. No
I feel like I'm
excuses.
in 1850.
Let it go. Does anybody have any questions or comments regarding this topic? Or even, I know we didn't have much time last time. We could even cover the last one Mark did too.
Love it. Going easy on us.
Katie said, great presentation, Mark. Thank you. Thank you so much. So we're all experts now. I love it. Mark, see? Just that awesome, dude. Just that good.
Mark, what I really appreciate about you, I've heard you say it multiple times in these rooms, but you'll say like, look, if anybody has any questions, or if you get a weird test, like, please always feel free to reach out to me. And I just always appreciate you, sharing your resources with us along the way.
You're welcome. And people actually do. I mean, I don't want to be like the go-to urine guy or whatever, but like, and I'm sure multiple could attest to like, there's times when there's just not an answer either. I didn't include it today, but there's cases where it comes up where it's like, even when you do the screening and the test, it's still, that's why we have our professional relationships to try and figure things out and work through it. So,
yeah. So I should not have you saved as the go-to urine guy in my business contacts. Is that what you're saying?
come up with a better name, then I'm fine with it.
Yeah, I'll work on it.
I love that. Love that for you. Tom, I see that you raised your hand. Go ahead.
Yeah, thanks, Mark. Nice job. Would you talk a little bit, for those of you involved in telehealth, how you handle screening and testing with folks who, when you're gathering a sample from somebody remotely?
Yep. So our program here in Morgantown, we're doing drug screens 2 different ways for our telehealth program. We do a certain percentage of each group with an oral swab kit, and then a certain percentage we still bring them in for urine drug screens.
Yeah. And you observe that buccal swab via telehealth?
Yep. So they stay on camera the whole time. They open it on camera. Sometimes they don't capture enough saliva on their cotton swab, so they have to spit directly into the canister, which is lovely to watch. But yeah, we observe all that on camera, and then they, hold it up and they're, oh, there we go. Jordan just showed us one. and then the results eventually pop up front. And now if what a patient shares is not what shows up on their screen, then we'll still bring them in person for a drug screen.
Thank you.
Yeah.
And back to Mark's observation about baseball, all you have to do is watch a baseball game to see people spitting.
Yes, that is so
Love
true.
it.
Love that. And thank you so much. Great question, Tom. Perfect. Thank you so much, Katie, for answering that too. And showing us, Jordan, can't forget you sharing carried and showing us that. That was awesome. Just great teamwork. Just love the vibe. Does anybody else have any questions or comments?
I think I've developed an obsession with floral shirts now. So thank you, Dr. Houston.
Floral and flannel, right?
Very welcome, Derek. And you wear it proud.
One additional comment, I looked up 42 CFR Part 2, and it goes with it, whatever the state regulations are with regard to minors and consent. So if it's 16 in the state, and then it's under 42 CFR, that's the same thing would hold true. Don't know if anybody's interested in that or not.
Thank you.
Yeah, that was awesome. Thank you for looking that up and sharing that.
Absolutely. Thank you so much. Truly. All right. Well, I just have one single announcement and won't be seeing you guys until September 12th, but Katie will be discussing standards of practice. So hopefully the weather's a little bit cooler and nicer then, and I look forward to seeing everyone. Have a great evening. Bye-bye.